Hi everyone, thanks for coming today. It is my great pleasure to introduce Melissa Hooijmans to you. She studied human movement science at the Free University of Amsterdam and then moved on for a PhD to the Lijing University Medical Centre, where she investigated different quantitative MR methods to measure muscle diseases, particularly in Duchenne and Becker muscular dystrophy. After that, she graduated in 2017 and then came to the Amsterdam Medical Centre, where I actually also met her, to develop quantitative MRI methods to map muscle oxidative capacity in young and elderly participants. And for that, she also received several prestigious grants actually to develop her own ideas. And now she is an assistant professor, and I'm very happy to have her here to tell you about non-invasive magnetic resonance platform to study muscle exercise capacity in healthy and diseased skeletal muscle. So please take it away.
The talk today is divided in 3 parts. So I would like to briefly highlight why it's important to develop a platform to measure muscle oxidative capacity in diseased and healthy skeletal muscle. And then I would like to introduce the 2 platforms we now have up and running in Amsterdam UMC, one for arm cycling within the MR bore and one for dynamic leg cycling in the MR bore. I would highlight some pilot data and healthy controls and also some preliminary data in patients with neuromuscular diseases. First, I would like to start with some background. Antonia already introduced that I have been working with skeletal muscle and MRI for a very long time, but I've mainly focused on using quantitative MRI techniques to look at muscle structure and to map, for instance, disease progression in patients with neuromuscular diseases, or to look at recovery of hamstring injuries in professional athletes. But we all know that in the end, muscle is very beautiful just to picture with the MR scanner, but in the end, you're using your muscles. So if you really want to learn something about muscle and whether muscle is really recovered back to healthy tissue, or whether a patient can still do certain things, you would like to investigate the muscle during exercise in the MR scanner rather than in a resting position. And that's also why I slightly moved to a different field, so from neuromuscular diseases to athletes and now back to aging, because we all know that the world population is aging due to the higher life expectancies and the reduced birth rates. And when I consider myself in 60 years, I would like to look like this lady here on the screen, still very healthy and still very active. But the truth is that the majority of people who age end up impaired in muscle function, maybe even limited in mobility due to risk of falling and also lack of exercise. So yeah, the main hallmark of aging is a progressive decrease in muscle function. And if you think about muscle function in general, you can divide it into 2 aspects. So you can think about muscle force, so the force generating capacity of the muscle tissue, but also the endurance of the muscle, which is often defined as oxidative capacity. And oxidative capacity is the maximum amount of energy one can generate during and after exercise using oxygen. And if you would divide that in 2 very broad systems contributing to the oxidative capacity, you will end up with the cardiovascular system, so the cardiac muscle, the lungs, and also the major vessels and the microvasculature running towards the muscle. And then within the muscle, you have the mitochondria, which use the supply of nutrients and O2 brought by the cardiovascular system towards the muscle to produce energy. And those 2 processes combined are very broadly and on a lower scale defined oxidative capacity. So we know that exercise capacity reduces with increasing age. So here on the screen, I'm showing a schematic picture of a skeletal muscle, which is black on the outside, and then you see some fibers within, and within the muscles you have the mitochondria. And on the outside, you have the blood supply, and the blood supply brings the nutrients and O2 towards the muscle. It diffuses within the muscle towards the mitochondria, which uses these nutrients and O2 to generate energy and CO2, and then the blood supply on the other side will bring the CO2 back towards the lungs and breathe it out. And that's how we can exercise and use all the nutrients and oxygen to produce the energy. We know that with age, the exercise capacity decreases, but there has been a lot of mixed results regarding which of those two aspects, either the level of tissue oxygenation, so the amount of blood supply bringing the oxygen towards the muscle, or whether the mitochondrial function is the limiting factor in exercise capacity with increasing age. And so far, most studies also only investigated either one of these aspects. So they either focused on the microvasculature or they focused on the mitochondria within the muscle, but never a combined study of the two. So the goal of the project within the Amsterdam UMC was to set up a platform to measure oxidative capacity and figure out what the main factor attributing towards the decrease in oxidative capacity with increasing age is. And as you all know, the elderly population is a very vulnerable population, so you would like to use non-invasive technologies to investigate all these different kind of processes within the muscle tissue. And the other thing is that if you're looking at skeletal muscle during exercise, you want to investigate it during a realistic exercise. So not like small muscle tissue, only like hand grip exercises or laying in a supine position on the bed in the MR scanner and only using your foot from extended to flexed position. Because in daily life, you do way more than just like using a grip strength exercise or only moving one foot. And with those kind of exercises, you also do not really involve the cardiovascular system. And the third thing we were aiming for in the development of this platform was to be able to simultaneously measure both capillary function and mitochondrial function to be able to distinguish the contributions to the reduction in oxidative capacity with increasing age in skeletal muscle. So yeah, we have been working on the development of such a platform, and I'm gonna give you some more details about it in the next slides. So most of you guys know, because you're also in imaging centers, that with MRI you can non-invasively measure capillary function and mitochondrial function using MRI. So you can make very nice images of the muscles using proton imaging, and you can sensitize those images towards capillary function using T2 star acquisition, where you can measure the level of tissue oxygenation. In addition to that, you can also focus on another aspect, so using phosphorus spectroscopy, which has been done here also quite often, by placing a region of interest, a voxel of interest within the muscle of interest, and then within that voxel you measure different phosphorus metabolites. And the amplitude below the peak is an indication on how much of those metabolites are present within the voxel of interest in your muscle. And we can measure the dynamics of those peaks over time to give a better indication on how well the mitochondria within the muscle are working. And the nice thing about these two different measures is that the tissue oxygenation focuses on the proton, while mitochondrial function focuses on phosphorus, which allows you to measure them very easily directly after each other, because they're not really involved with each other. So you can measure mitochondrial function while the proton signal is still recovering after an RF pulse, which allowed us to use interleaved acquisitions on the 3 Tesla system. So we acquired a proton image to look at tissue oxygenation, and directly after that we also acquired a phosphorus spectrum, and then we switched on and repeated that dynamic measurements for multiple times to have an indication on how the level of tissue oxygenation and the mitochondrial function changed over time in rest, during exercise, and during recovery. And yeah, the third thing I already mentioned is that generally when you look at studies performing exercise in the MR scanner, they make use of very small muscles. So they do hand grip exercise and focus only on the muscles in the lower arm, or they move their foot back and forth and they only focus on the muscles in the lower leg. And they often also only use rest exercise paradigms, which means that they only acquire images while somebody is in resting position. So they do some exercise, then relax, acquire the image, do the exercise again, and then acquire the image. But ideally, you want to acquire all these data during dynamic exercise. So while somebody is doing, for instance, cycling exercise or stair climbing exercise within the MR scanner, because without that dynamic exercise, you also do not really involve the cardiovascular system well enough to really investigate exercise capacity within skeletal muscle. So we try to develop a platform where we use a daily life activity as exercise setup. So we move towards arm and leg cycling, and especially in the Netherlands, where a lot of people cycle, it's a very common activity to do. And we use an incremental exercise protocol where you can increase the load during the cycling experiment every minute to until they couldn't perform the exercise anymore. Just to give you an idea on how the platform looks like. So here on the left side, you see our 3 Tesla, or right side, sorry. You see our 3 Tesla MR system, and then here we have a setup which can lift the MR compatible ergometer just above the MR bed, and then you can move it back and forth so that you have enough distance from the participants with the walking pole sticks to perform the cycling exercise. I'm gonna go to the next slide, and then you can see how somebody can cycle within the MR scanner. So there's enough space, and the only movement the person is performing is like moving the lower arms up and down using walking pole sticks, which are attached to the bicycle, and then you're cycling around. And this part here, you can flip over the wooden wheel, and then you can increase the load during the cycling experiment to make it heavier every minute. And then just to give you an idea on how much space there's still left in the MR scanner. So if you're a really tall person with really long lower arms, then at some moment in time, the top of your hands will hit the top of the bore, of course. So then you have to like move them slightly inwards to be able to still perform the exercise. So we had the platform there. So we had, go ahead.
And you don't have the coil there, right?
No.
Okay.
So so the coil we're using back then was a surface coil which you could attach to the backside of the upper arm, which is it has a diameter of 14 centimeters. So it just fits on the backside, and you position the arm on the bed. So the coil is just laying below the upper arm, so it doesn't really take that much space. But of course, it's still like on the outside of the field. And the thing was that we only had a coil which was a surface coil for phosphorus. And so we were using the bore of the tunnel to do the proton imaging back then. So we've been working to optimize both data acquisition, so the phosphorus part to look at mitochondrial function. So to give you an idea on how a phosphorus spectrum with the surface coil looks like. I think, I'm not sure how many people are familiar with the phosphorus spectrum, but maybe a few. So this is a resting spectrum of the triceps muscle, so the muscle on the backside of your upper arm. And there you have phosphocreatine and independent ATP peaks and PI. And you can use the difference between PI and phosphocreatine to calculate PCR. And we also try to collect some data while doing the cycling experiment in the MR scanner. And then you see that indeed the amplitude of the peaks change, and also the distance between PI and PCR changes a little bit. But we were actually quite happy with the line width of the peaks and the signal to noise ratio while moving the arms in the MR scanner. And also to keep in mind, like when you position the MR scanner, ideally you want the region of interest you're imaging in the middle of the tunnel. That's of course not the case because the arm is always on the outside side of the body. So we try to move the participants slightly to one side to have the arm we're imaging more in the middle of the tunnel. But yeah, of course, it's always still more on the outside. And in addition to the phosphorus, we also try to optimize the T2 star acquisition to look at the tissue level of tissue oxygenation. And here we ended up having troubles with the fact that the arm was positioned more on the outside of the magnetic field. And we were scanning with the body coil rather than with a dedicated surface coil to acquire the images. So we had some shimming difficulties, which resulted also in some signal dropouts here in the later echo images. And that's why we decided to not only image the arm, but image the complete abdomen area, which allowed us to shim much better. Nobody really knew why, because it's also all moving. There's a lot of airspace there because of the lungs, of course, but somehow it resulted in better image quality. So we moved forward with this protocol. And then, we ran some pilot experiments where we collect data in 6 participants in a varying age range from 22 to 59 years old, with the platform shown here on the screen. And we made use of an interleaved MR acquisition where we used a pulse acquire phosphorus spectroscopy acquisition, used an adiabatic pulse, and after that we acquired a multi-echo T2 star acquisition. And the dynamic time for acquiring a T2 star image and a phosphorus spectrum was around 3.8 seconds. And then we repeated that during the exercise protocol. So participants performed arm cycling and we increased the load every minute until they couldn't perform the exercise anymore. And the total experiment took around 250 dynamics, in which we first had the resting phase to have the baseline data, then the exercise period, and then the recovery period afterwards. And then we did some data analysis. So we used the FIDs to fit Amare's toolbox in YMRI. And we use customized prior knowledge files, and as metabolic outcome parameters, we focus on the level of phosphocreatine depletion. So to go slightly back. So the drop in PCR between the resting position, so this amplitude versus the amplitude at end exercise. And we also looked into how quickly that peak phosphocreatine recovered back to its original height after exercise. And then we looked at the 95% recovery times in seconds. And we looked at the end exercise pH, which is an indication of the acidification after exercise. So ideally, if you're interested in oxidative metabolism, you don't want the pH to change too much. But if it happens, it also lengthens your recovery time of phosphocreatine. And for the level of tissue oxygenation, we evaluated the T2 star acquisition, and we created R2 star maps using a vendor-specific mono exponential fitting routine. And then we drew regions of interest for this muscle we were interested in, which was the muscle on the backside of the upper arm. And then we normalized those values towards the baseline data to give an indication on what the post-exercise response was in tissue oxygenation. And then we mapped the maximum value it reached and how much time it took to reach that specific value. And we looked into the relation between those 2 outcome measures, because some other groups have been doing separate works as well to see how they relate, but they didn't do them in one experiment, but they did the same experiment twice to compare the phosphorus data with the capillary data. And just to give you an indication on how the data sets looks like. So here the first spectrum is a resting situation, and then the participants started to do exercising over time, and here at the end it's the end exercise spectrum. And you can see that both participants vary quite a lot in what their end exercise state was, but they both reported a very high level of tiredness after the experiment. So you really see, I lost my mouse, yeah, that here phosphocreatine is like almost completely gone. The eye is very present, and here you still see some, tiny bit of PCR left and a little less PI there. And then you can also look into more detail in how all those parameters recover after exercise. So we were very happy that we could generate good quality data sets using this interleaved acquisitions and the specific arm cycling platform. And then to give you an indication on, like, also here the variations in our primary outcome measures. So on the left side, we have level of creatine on the y-axis, and on the x-axis, the time in seconds. And you can see that here in rest, phosphocreatine is almost the same level. While you start arm cycling, phosphocreatine starts to deplete. And then at a certain moment in time, it reaches relatively low level, and then the person cannot really exercise anymore, so it stops. And directly after that, you see the recovery. What's my mouse in here? Yeah, the recovery of phosphocreatine back towards resting values. In both these participants, they went really, really deep. So there's quite some drop in intracellular tissue pH, which resulted in a longer recovery time for phosphocreatine. And here on the right side, you see the R2 star measures, where you also have the resting data completely stable. Exercise is not really possible to measure because the T2 star acquisition is also very sensitive to motion and towards inhomogeneities in the field. So we decided to get rid of the specific exercise data and only look at the post-exercise response. And here you can very clearly see the difference between the two participants, one having a much bigger response post-exercise than the other one. But the timing of the peak was actually relatively similar to each other. So we ended up with high variability, not only between these two participants, but between all our participants in the pilot data. So we also did some correlations between the level of PCR depletion and the time it took to reach the peak of tissue oxygenation, for instance. And we did not see very clear correlations, which is also quite logical when you have such a small data set, but it was just to get a feeling about how the data corresponded to each other. If you look at these graphs here, you can see that there's some tendency between the maximum R2 star response and the PCR recovery times, which you can see here a little bit. And we saw that with the lower end exercise pH, we had a longer time to peak, which is also maybe slightly related to each other. But to really look into these correlations, we have to collect some more data in larger populations. So overall, with this platform, it was feasible to collect both phosphorus data as well as quantitative T2 star data during dynamic arm cycling exercise within the MR scanner. We reached a temporal resolution of 3.8 seconds, which was good enough to indeed look at the dynamics of the phosphorus spectra and also the BOLT or the R2 star responses post-exercise. And what we found in this combined experiment was in good agreement with previous reported work where they only investigate either the phosphorus dynamic series or the R2 star series in healthy individuals, using also different kind of exercises. And the other nice thing is that with this platform, we saw that PCR depleted up to 80% in most of our participants. So it's really possible to go all out with this platform in exercise, which also indicates that you have near complete motor unit recruitment in the muscles, which is nice to really look at how the muscle functions in participants. And we looked into some correlations and we found some tiny tendency towards some correlations. I'm not going to go in more depth there. And then, yeah, we were very happy with the arm cycling experiment. So the question is, why would you like to move towards leg cycling? Now, we know that in addition to aging, also in a wide variety of other diseases and muscle disorders, they are also affected by exercise intolerance, but then primarily the leg muscles are affected earlier than the arm muscles. And performing arm cycling exercise appeared to be really difficult for our elderly participants. So the coordination of leg cycling seemed to be more easy for participants than the arm cycling experiment. But going to leg cycling is also difficult, because with the arm cycling, the participant was like laying on the table and only moved the lower arms. But while you're cycling with your leg, the whole leg is moving to the bore, and then you have to image in the exact same position to actually have a phosphorus spectrum or a bolt image. So we had to figure out some way to synchronize with the motion cycle, and also maybe fix the rhythm at what participants are cycling to keep a constant data flow also during the exercise period. Yeah, so here you see the same bike, but then set up for the leg cycling experiment. So yeah, in the red square you see a pedal used for a race bike. And then we had all race bike shoes in different sizes, so the participants could wear those shoes, and then we can click them into the pedals, and then they don't have to fixate their foot on the pedal, but then the shoe is fixated to the pedal, so they could cycle. And then if somebody has weakness around their hips, you can strap also the legs slightly together so that they stayed in the same plane without the legs falling outside to the side of the board. And then the other thing is here highlighted in red is a device to stabilize yourself with hand grips, because while you're cycling with your legs, you're always pushing yourself a little bit higher on the table, and then at some moment in time your legs are completely stretched and there's no way of doing the cycling experiment anymore. So like the hand grips next to your side work really well for healthy controls. But if you want to ask a patient with neuromuscular disease to perform such an exercise, you cannot also ask them to stabilize themselves and use even more muscle force. So we came up with a jacket which you can put on, and then instead of the hand grips, we could fixate the jacket to the bicycle, and then the participant remained in the same position, and they could still do the cycling experiment without also tiring their arm muscles. So yeah, it's a lot of effort to put somebody into the MR scanner, but when they're finally positioned, it works actually quite well. And we also got a new coil to be able to use only one coil, a double tuned one, for both the phosphorus and the proton. So yeah, we collaborated with Rapid Biomedical, and they customized the coil slightly. So we ended up with a proton receive only coil and a phosphorus send receive coil with different loop sizes. And then you can see it here on the screen. You have openings here, and you can fold it like around the leg and then strap it with an elastic band, so it fits around every leg, lower leg, upper leg, lower arm, upper arm. So for our experiment, it's quite convenient. And then we worked on synchronizing the leg cycling with our MR acquisition as well. And we realized along the way that it's impossible to synchronize both the phosphorus spectrum and the T2 star acquisition with the motion cycle. And based on our data quality of the arm experiments, where we already couldn't use the data, the T2 star data during the cycling experiment, we decided to go for synchronizing only the phosphorus data with the motion cycle. And for that, we started with telling participants to follow like a rhythm on a screen outside to fixate the rhythm, and then time it according to their cycling motion we forced up on them. But that didn't work so well, so we created a trigger which was placed then on the wheel and associated with the pedal position of the leg we were imaging, and then every time in the exact same position the acquisition of the phosphorus spectrum started. And that worked quite okay if you kept a constant cycling pace, which is okay if you have healthy participants because they can, but if you end up with patients or elderly participants, they get tired and they have trouble performing the exercise anyhow. So yeah, we also had somebody inside the MR room to give verbal feedback towards the participant to tell them to either cycle faster or slower. So I could see outside where you normally see like the heart pace of a participant, I see the cycling rhythm. So I try to force them within a rhythm of 60 or 70 rounds per minute to get like a relatively constant cycling pace. And then you end up with quite good spectral quality, not every time, because sometimes just doesn't work, but you have good enough data to look at the resting period, the exercise period, and of course the recovery when somebody is laying still again. So give you an idea on like what kind of quality images we get using a specific coil. So we were quite happy because it's a surface coil. We were expecting to have way more signal drop out on the backside of the leg, because I positioned it around if your upper leg on the front side. So the vastus lateralis is one of the quadriceps muscles. So it was positioned here, and there we have good signal quality, but also still the posterior side of the leg is here visible in the image. And then again, we acquired 15 different echoes, and we registered the data over the different echoes and over the different dynamics in time. Then we drew a region of interest for our muscle of interest, which is shown here on the right side. And then we used a pixel-based mono-exponential fit only within our region of interest. And then we mapped the R2 star response also towards the pre-exercise situation, because that worked really well for the arm experiment. But here again, after cycling, it's very difficult to get the leg in the exact same position post-exercise as pre-exercise, and then you end up with a slightly different shim, and then you get an offset in your R2 star signal. So for this experiment, we decided to normalize toward post-exercise rather than pre-exercise to see the signal response. And if you look at this curve here on the screen, you can also see that it like seemed to be normalized here anyhow at post-exercise values. And then for the phosphorus spectra, we were also slightly scared whether the shim would work good enough during like that dynamic motion while moving around. Now, when we looked at the spectra, even like during exercise, we were quite happy with the signal to noise, but also with the relatively small line widths of the individual peaks, which allowed us to quantify phosphorus, creatine, of course, and MPI. And so after development of the platform, we also were interested whether it would also be feasible in patients with neuromuscular diseases or in an aging population. So we set up a study where we investigated 3 different patient populations, all with exercise intolerance, but all with different origins. So the data I'm going to show you very briefly is of a mitochondrial myopathy, so a disease where we know that the mitochondria are affected and limiting their exercise capacity. And this specific disease is characterized by muscle fatigue and also muscle weakness, and it starts primarily in the eyes and then moves towards the other muscles in the body. And in addition to that, we also investigated 2 other patient populations, but I'm gonna leave that for now because we're not going to focus on that. And we did the same for the aging population, where we investigated young controls, older controls, and older controls with accelerated form of aging. So we had a study population of 10 healthy participants and 9 patients with CPEO. We used our whiteboard Vitesta MR system, the double-tuned coil, and the MR-compatible ergometer I just showed. And here again, we let the participant perform exercise. So first they had a minute of rest. Then they had an exercise period, and every minute we increased the exercise load, and until they couldn't cycle anymore within our 60 to 70 rounds per minute cycle pace. And then we looked at the recovery, and we mapped a total of 400 dynamics, and each dynamic also took around 3.8 seconds, like at rest and also during recovery. And during the cycling, of course, it's forced upon by the cycling rhythm of the participant. So if it cycles faster, then also the dynamic time changes slightly of the complete acquisition. And then we use the same interleaved MR acquisition. And to look at the post-exercise response, instead of normalizing it to pre-baseline, we normalized it to end exercise. And then we fitted a composite function describing the hyperemic response, so the R2 star response post-exercise, with a linear first part of a curve and exponential second part. And we quantified the maximum response and the time it took to reach that specific peak. And for the phosphorus data, we looked into how quickly phosphocreatine could recover back towards normal values. And we also looked into how pH changed within the muscle over time. So normal relaxed muscle tissue has a pH around 7. And during exercise, you would expect it to drop. And especially in patients with mitochondrial myopathy, it drops really rapidly to a very low level. And then at some moment in time, it starts to recover back, but also the recovery of that takes a little longer. So we looked into those 3 parameters, and then we compared those CPO patients with our healthy controls. And we saw that with the same kind of exercise, they reached a similar level of PCR depletion. So the exercise for both groups was of equal heaviness somehow. And then we looked at how quickly PCR could recover back in those participants. And we saw that the recovery times of the patients with CPO were relatively longer compared to the recovery times of our healthy controls, which was also what we were expecting. So we were quite happy with the results, because it showed also that it is feasible to use such a platform for patients with neuromuscular disease and get also results which are in line with the expectations and also the knowledge already known in the field. We didn't see any differences in end exercise pH, which surprised us a little bit. And we didn't see any differences in R2 star measures, which was according to our expectations, because we were assuming that only the mitochondria are affected in this patient population and not the capillary function bringing the oxygen towards the tissue. So overall, all participants, also the other patient populations, were able to perform the exercise study with this leg cycling platform. And specifically for the CPO patients and the healthy controls, we saw a similar level of PCR depletion, indicating that they had a similar level of exercise done in the MR scanner. And then with recovery, the CPO patients ended up with a longer recovery time, indicating that there's something going on with the mitochondria in the skeletal muscle. And we didn't see any changes in R2 star measures. So overall, we were quite happy. And these are the 2 platforms we now have been using in quite some studies in Amsterdam University. So I'm happy to answer any other questions, and I would like to thank you guys for your attention and listening to me.